Just a little in depth. This is basically another PowerPoint presentation in regards to the last video that you guys watched. If you have not watched, please make sure you watch the previous video on HEDIS measures. So let's get into it. Calculating the risk score. Each member is assigned a risk score. And the way they make up the risk score is basically based off the demographics, characteristics, plus the health status. And that is what equals the risk score. The higher the risk score represents members with a greater than average burden of illness. The lower the risk scores represent a healthier population. And as I stated before in a previous presentation, it may be false due to inaccurate diagnosis coding and also incomplete chart documentation. So just to elaborate a little bit on this slide, basically to sum it all up, the higher the risk score means the more sick the patient is. The lower the risk score, it just means that that patient is healthier than most. Individual risk scores. Each enrollee risk score is based on the individual's demographic and health status, as I stated before in a previous slide. A risk is calculated as the sum of these demographic and health factors weighed by their estimated marginal contribution to the total risk. The calculation relative to an average amount spent on the patient's health. So anything that the insurance company pay out is basically just to help the providers prevent any other illnesses, to make sure that they're taking care of their patient, to pay for medications, to pay for hospital in-stays. That is another slide that you guys can watch. It will be up soon. However, I do have an example of how they sum up the risk score. So let's say we have an average of $1,000, okay, for any patient, any member. And we have a female in office that's around the age of 45. She is not really high risk. She's half of that, so we're going to give her a 0.5 risk factor. She only have minimal conditions, so her let's say it's $700, so we're going to give her the 0.7 risk factor, and we have to sum that up to get the risk score, which is the 0.5 plus the 0.7 equals the 1.2 risk score. So the 1.2 risk score is what she will be being paid out. Well, not, she won't be paid out, but that is what the health insurance will pay out to the provider office, 1.2 rate per member per month. So the risk score actually is made up of this chart that I have listed. It's 68,000 total ICD-10 codes. And we have 8,830 ICD-10 codes that actually map to the CMS HCC model, and 25 condition categories, and 79 HCCs. So I've also listed here a chart of the disease HCC categories, and this is basically how payments are made with the disease hierarchy. They do have an example listed below, and here it is. It's just if a beneficiary triggers disease group 135, which is acute renal failure right here, and 136, which is CKD stage 5, then disease group 136 will be dropped. In other words, payment will always be associated with the DG in column 1, which is here to the left side. If a DG in column 3 also occurs during the same collection period, therefore the organization payment will be based on DG 135 rather than 136. So basically, to sum that up, the lower the HCC category, the more severe it is, and most likely that is the one that the CMS and health insurance will pick up, and the others will drop. So you only get paid for one disease in the category, and which most likely probably will be the highest. If you have any questions, please make sure you visit the website. So once you have the patient in office, the provider documents the progress note. Then you have the medical biller who would read over the progress note, and now it's time for the data submissions. So once the medical biller or coder actually submits the claims, it goes to a clearinghouse or it automatically goes to the health insurance company. And that is just behind the scenes. So the transaction between the healthcare providers and insurance company begins. The healthcare provider records all the medical services and their costs offered to the policyholder. So just to elaborate on that, every time you step inside a office, hospital, there is a charge. Whatever they do to you, there's a charge. So that little computer that they always typing in your vitals, etc., or the paper charts, or that little thing that the provider is actually looking at instead of looking at you, that's just calculating up your total expense for that visit. Um, so the healthcare providers, as I stated before, records all the medical services and their costs offered to the policyholder. This record is known to be the medical claim or bill. While working for healthcare providers, medical billers and coders are responsible for creating this record and sending the claims out to the policyholder insurance company, which has three options, which are one positive and the other is negative. So they can accept the entire claim and pay it in full, deny the claim on an account of a billing error like incorrect patient information, member wrong number, anything, they can deny the claim. And then the health provider will actually have to correct it and resend it. Or they can just reject the entire claim, usually on account of the services that's not being covered within the health plan. So the policyholder will have to pay out of pocket. So here I created a case study with a medical record, and on the next slide I'll actually show you the coding examples. So we have John Joe Smith, who's 66 years of age, who comes in with a complaint of lower back pain and numbness and tingling in the lower extremity. The patient does have a past medical history of diabetes with neuropathy, major depression disorder, and a toe amputation. All the systems were reviewed and they were negative except for the lower back pain and numbness and tingling. The patient is 64 inches, weighs about 245, and the BMI is 43. The blood pressure is 130/82. And everything seems to be good with the exam except for the patient is morbid obese, and the foot exam does reveal decreased sensation with the great toe amputation. So here in the assessment plan, you have this is a medical screen exam, preventive care discussed. The patient is diabetes type 2 stable, continue the current treatment plan. Neuropathy stable, continue the current treatment plan. And then you have major depression, mild, stable, continue the treatment plan. And citalopram as needed. PHQ-9 is a 5, dated on today's date, which was 1/28/17, and the patient also has CHF, which was evidence noted on the echo back on 1/5/2017. And then you have the provider's signature electronically. When he did not sign it on the same day, he signed it on February 4th, 2018, which is actually okay. So I have listed a case study and how the risk score is broken down. So I'm just going to elaborate on it a little bit. Based off the progress note that we just read together, the patient is 66 years of age. So just because the patient is 66 years of age, they're going to start him off with the 0.288 risk factor. Now this goes hand in hand when I say the risk score is sums up with the demographics and the health status. So the 0.288 is just the just the demographics, okay? Now Next, we have from the assessment plan, it says medical screening, which is not a risk factor, so they did not give you anything, okay? Then you have the diabetic neuropathy, which is E1140, HCC group 18. And yes, they did give you some credit for it. You get 3.368. Then you have the major depression disorder, which is mild, F32.0, HCC category 58.330. Then you have morbid obesity, E6601, category 22.365. Now, as you see, I group those together. Anytime you have morbid obesity, you have to make sure you document the BMI. That is a paired diagnosis. The BMI for this patient was 42.5, so we're going to code the Z6841, which is the same category, 22. And as you see right here, it tells you to go above to the 0.365. So if the patient has a more BMI of 40 and over, you can it automatically gives you the category 22. But make sure that the provider is documenting morbid obesity, overweight, whatever he feels the patient is. But anything 40 and over is morbid obesity. Actually, 35 plus comorbidities like diabetes, hypertension, heart disease, that's actually morbid obesity. So keep that in mind. You also have the left toe amputation, which is a status code, Z89412, category 189, and the risk factor is 0.779. Then you have CHF, which is I509, category 85.368 risk score. Now, just because the patient has diabetes and CHF, it automatically gives you an extra addition 0.182 because it's a disease interaction. So with that, you have a risk score of 2.68. And as I stated before, the higher the risk score, the patient is kind of ill. He's not so healthy, and an average risk score probably would be 0.5 or 1. Anything over that, the patient is starting to get some type of disease or disorders and should have attention to. What else? So this patient has 1, 2, 3, 4, 5 HCC condition categories, okay? And then here on the left-hand side, you have the CPT codes and the ICD-10 codes, and this is just how you would submit the claim to either the clearinghouse or the health medical insurance to be paid out. And you have to make sure that these coexist with you have to make sure that these codes are relative to the ICD-10 codes, because if not, as I stated before, they will reject and you have to resubmit again. And I have 3 examples of what a software looks like when you're submitting a claim. And this is just an example so you guys can get familiar when you do start your career path. Here you have the CPT code. There you have the diagnosis code and the modifiers. Now, some of these, depending on what type of plan you're coding or billing, you will have to input modifiers. And that will be another slide if you guys are interested. And then the charge. As I stated before, anything that the provider does on you, they do charge. Okay? And then the copay will be applied if the patient had to pay anything. And these are the previous dates here. So as I stated, this is just an example of what a software looks like when you're submitting claims. Likewise here, Here actually are the CPTs that's listed in the software, and you here as well. So some softwares, they actually have the ICD-10 listed, the catalog, as well as the CPT codes listed as well, which is a great software. If you're if you're thinking about investing in one of those or creating a software, please keep in mind that it's very imperative to have a CPT, HCPCS, and ICD-10 code implemented inside your system, because your coders will not be too happy and will not produce that much. I know from experience. Here below, this is where the coder is entering the CPT code, and here's the diagnosis code. Here is the modifiers, and yes, so that is it for this one. And then here looks like you have the date, the patient codes, the patient balance, the date it was created, the procedure code, the diagnosis code, the modifiers, the amount. And this one actually gives you option if you want to print out the claim. So you need those options as well, because they do have audits, and I believe it's Medicaid where you have to print the papers and submit them. So yes. Now for the clearinghouse, most companies are middlemen. As I stated before, you have the patient that comes in, sees the provider document and record the progress note. The medical biller will submit the claim, and once they submit the claim, they either submit it to the health insurance or they submit it to the clearinghouse. In medical billing, companies forward claims information from the healthcare providers to insurance payers, which is known as the clearinghouse. Clearinghouse checks the claims for errors and makes sure that the procedural CPT, HCPCS, and diagnosis codes are valid and appropriate for the diagnosis submitted with the procedure codes. Each provider chooses which clearinghouse they would like to use to submit the claims. And as I stated before, this is just the medical billing process. Here on the right hand side, you have the insurance verification. You need to check the patient's demographic entry, the charge entry, the claim submission, the payments posting. Once you post that payment, you need to follow up to see if it was denied or not. And if it was denied or submitted, the health insurance plan will actually send over a report, which is called EOB. That is another presentation that I can do for you guys if you like. The best top clearinghouses in 2017 that I actually Googled, you can find this, just search the best top clearinghouses if you're in need of one. You have Navicure, Apex, Claim MD, Gateway, RealMed, Avelity, MD On, MD Online, Relay Health, Health Smart, Datatron Solution. I've only worked with Health Smart, Avelity, Gateway, and I believe Avelity is the best out of the three that I've actually worked with. So, I mean, it's up to you guys, but I really like Avelity. They give you the gaps, they give you the insurance information, any labs that was performed on that patient from anywhere, hospital stays, the prescriptions, the medication the patient was on, all the risk factors that the patient has from, I believe it's 4 years, 2 to 4 years, I believe, I'm not sure. And any diagnosis that the patient has ever had, whether it was an acute condition, an error, or whatever the case may be. So I really believe Avelity is a great clearinghouse. Okay, so professional billing 837P and CMS 1500 claim forms. By submitting a claim varies from different EMR systems and types of services. So on the right hand side, I have the services listed, but you actually can just either go to CMS, and review the 1500 claims forms, or just Google it. The form CMS 1500 is the standard paper claim form that the healthcare professionals and suppliers use to bill Medicare administrative contractors when a paper claim is allowed. CMS designates the 1500 health insurance claim form as the CMS 1500, and the form is referred to throughout this fact sheet as the CMS 1500. 837P is a professional, that's who uses this form, is the professional providers, and this is the standard format used by healthcare professionals, as I stated, and suppliers to transmit healthcare claims electronically. So this is just an electronic form setup. And as I stated, the table listed shows the type of services that certain provider types or specialties can bill on the CMS 1500 claim form. In addition to billing Medicare, the 837P and Form CMS 1500 may be suitable for billing various government and some private insurers. Data elements in the CMS Uniform Electronic Billing specifications are consistent with the hard copy data set to the extent that one processing system can handle both, which is actually great. And here is just an example of what a CMS 1500 form looks like. And going back to what I stated at least 3 times, this is just a typical medical visit claim and billing flow. You have the patient who visits the doctor's office, front office who's supposed to check the patient in, make sure all the information is correct, the address, phone number, billing address, collect the copay if necessary, make sure that the insurance information is up to date. Then you have the doctor and or assistants that writes the super bill. You cannot code from a super bill. Okay? The provider must they shouldn't even be using super bills right now, so let's just say that the super bill is not there, and it says doctor and or assistants write out the progress note. Then you have the billing office, in-house or outsourced, based off the progress note, they generate the claim. It goes to the clearinghouse and they check for any errors. Then the clearinghouse submits it to the insurance company, and once the insurance company gets it, they send and generate the error report, if any, and send it to the provider. Then they send that out and they generate an EOB, either write the check and send a payment to the provider, or they will receive a EOB. I know this is a little off topic. Well, not really, because HEDIS and MRA HCC go hand in hand. So a few people reached out to me in regards to the domains of care. They wanted to know what they were. So you have 5 domains of care, and it's the effectiveness of care, access, availability of care, the experience of care, utilization and relative resource use, and the health plan descriptive information. I will also list I believe it's 85 or 83 HEDIS measures this year. I will do a PowerPoint on that. So make sure you guys thumbs up, comment below if you want to see more power presentations. The website will be up soon, so you guys can actually chat with me. Yeah, so for anyone who's actually trying to build a software or just new to this industry, just keep in mind that keep a lookout for any updates for CPT codes, HCPCS, and ICD-10. That is imperative, because CMS, they changed their updates often, and they just came out with a new update, so make sure that you review it. If you're certified, go to your website, AHIMA or AAPC. um, Also, make sure you do constant checks. If you're doing a software, make sure it automatically constant checks for errors, so you won't submit to the clearinghouse and you won't get back an EOB with errors. Just prevent that. You need to know all the performance measurements, the service quality assessment, and Medicare risk adjustment tools. Make sure you just Google. I mean, I taught myself, and I've been in this industry for about 10 years. It's very high demand, and I mean, just learn more. You can't go wrong with learning more. Um, Customize utilization reports and analytics. Make sure, if you're doing a software, that you have those options, because that's what users will look for. Providers, ACOs, MSOs will look for in a software. And to end this, to capitalize in this industry, we need a solution to measure, predict, and manage risk, to close the gaps in coordinating care, to manage costs and utilization, to measure and improve clinical quality outcomes, to leverage evidence-based care, and to collaborate with care teams. Um, yeah, so that is basically it. I have my reference on the next slide. I did not reference, I believe it's eClinical Works, for that amazing quote, to capitalize, and they are on right. They are absolutely right. In order for your business to be successful in the Medicare, Medicaid fields, you have to know how to capitalize in this industry. Um, so yes, my next PowerPoint, I probably will show you guys how I review charts. So be on the lookout. Make sure you visit my website, as I stated before. I would love to interact with you guys. Subscribe to my channel and give a thumbs up if you have any comments. If you don't like it, that's fine. Write your comment and explain to me why you don't like it. Other than that, I love you guys. Thank you for being so positive with me, and I will be back shortly.